Okay, well, isn't it exciting to hear how many disorders we can treat now in neurotology? Almost everything. And of course, that means we have to make a diagnosis. And that means we have to hone our clinical skills. And if there's one thing I'd like you to take home today is you can learn so much at the bedside from the history and from just doing a few simple examination techniques. So that's a real focus today. I'm happy to make any of my presentations available. Just send me an email. I probably can't send you all the videos, but certainly all the charts, and I think that's really important. So this topic, I'll kind of mix two things together, central vestibular disorders and nystagmus. You've already had the basic anatomy of the vestibular system. I'm not going to belabor it now, just to remind you that horizontal movements, information comes from the labyrinth into the vestibular nuclei, into the pons, the Dussen's nucleus, and then up for the control of conjugate gaze. Now, a very important point, and this will become clear when we start looking for skew deviations, is to understand a little bit about the pathway for vertical vestibular reflexes. And the utricle, the anterior and posterior canals, they project activity up from the pons up to the midbrain, third, fourth nucleus, interstitial nucleus of Cajal. And most of it, but not all of it, runs in the medial longitudinal fasciculus. So we're going to see examples of that. Now, you've already seen a bit about the ocular tilt reaction. I'm going to re-emphasize what Michael has told us. What can we really learn at the bedside that's going to help us? The problem which is going to come up is, how do we diagnose a stroke? How do we diagnose a stroke in a patient with vertigo? And there are going to be three things that you're going to want to become competent at to do at the bedside. That being said, you may have to put goggles on and measure the responses sometimes, but if you see an abnormal response, you're helped. So you're going to have to learn how to do a head impulse and interpret it. You're going to have to learn how to diagnose or detect gaze-evoked nystagmus, nystagmus that changes direction, whether you look right or left. And you're going to have to learn how to diagnose a skew deviation, a vertical difference between the two eyes, because those signs are going to help you decide whether your acutely vertiginous patient has a stroke. So Michael Hamagi, of course, and colleagues put a lot of this on the map. He wrote about a patient who had actually a peripheral lesion. It was a surgically created lesion, cutting the nerve to the utricle. And she developed what we call the ocular tilt reaction. You can see the head is tilted a little bit. There's a vertical difference between the eyes. One is higher than the other. And if you were to look at the back of the eye and see where the optic nerve head was and the macula was, you could see the eyes were rotated. And this triad is called the ocular tilt reaction. Head tilt, skew, vertical disparity between the positions of the eyes, and torsion, which of course we often measure by doing a subjective visual vertical with the bucket test. So when you tilt your head, think first of all what a rabbit does. If you're a rabbit, your eyes are out here, and you tilt your head like this. Normally you bring them up so they stay aligned along the meridian. That's a normal skew deviation in a rabbit. Now we have turned around, brought our eyes around, we are frontal-eyed, our eyes point this way, and when we tilt our head, we don't want this, we want this. It's called counter roll. And that's what you see right here on the left part of the slide. You see a normal response, the head tilts, the eyes rotate, and our perception of upright remains the same. It's normal. But when there's an imbalance in the system, the rabbit comes out, and we become lateral-eyed, and now our perception of upright is tilted. The eyes are counter-rolled, but also skewed. And you can see that in this diagram here, and that's the ocular tilt reaction. It's exactly the same as a spontaneous nystagmus, only it's in the otolith system. So when you have a canal imbalance, you get a nystagmus, spontaneous nystagmus. When you have an otolith imbalance, you get counter-rolling, skewing, the ocular tilt reaction. So we saw this bucket a little bit earlier. This is our bucket, which is very much like everybody else's bucket. A little line inside. Lars Friesen in year 2000 actually kind of put this idea in our minds, and then it was really put forth from the Munich group. And this is a simple test, and it is so valuable for lots of reasons. The other piece of technical help is with the tool of the ophthalmologist, and that's to detect skew deviation. This is a Maddox rod. I carry one around with me wherever I go. You never know what's going to happen on an airplane. And we'll show how, we're going to have a little practical, we're going to do all these tests. We're going to examine each other. We're going to find out how many defective patients there are in the audience today. This is Maddox. He's not strangling the patient. He's measuring how far she is from the wall. All right, what do you see here?
Front cover once more. Alternate cover, sorry. And we see an extra
Watch the lids,
deviation
too.
and a left hyperdeviation. Okay, let's stop.
Do the eyes jump up and down when we do the cross cover? Is there anybody who couldn't see that? Raise your hand, I'll show it again if you want me to. Should we show it again? You must be hungry, no one wants that. Okay, so this is a skew. We're doing a cross cover, and one eye, when the cover goes away, the eye refixates. The other one moves too, but it's under the cover, and then when you switch the cover, it goes the other direction. See the head tilt? You see the head tilt? Okay, this patient had an intranuclear ophthalmoplegia. This same patient we saw about an hour and a half ago with an adduction weakness, and she had a classical skew deviation, a head tilt. And the lesion is in the MLF, and this is very common with brainstem strokes. You're going to see a head tilt. Just look for it, and if you measure with the cross cover, you may often see this skew. Now, here's another patient. An elderly man presented with acute onset of double vision vertically, off balance, numbness on one side of the face and the opposite side of the body. Look at his video. Same thing, down, up, down, up. Sometimes if you watch the lid, it's a little easier to see. So another head tilt, the patient. The patient has a droopy eyelid, probably has a Horner syndrome. And if I told you this patient also had hiccups, would that ring any bells for a diagnosis? You know, we're getting down into the throat now. So hiccups, acute onset of double vision, being off balance, numbness on one side of the face, the other side of the body. This is a classical, anybody? Wallenberg syndrome. Wallenberg syndrome. So a stroke syndrome, and I'm going to get to those stroke syndromes in just a little bit. So Wallenberg syndrome, it's a stroke in the distribution of pica, posterior inferior cerebellar artery. It's a branch of the vertebral artery. It involves the dorsal lateral medulla, probably all remember that, and the caudal vestibular nuclei are involved. The caudal vestibular nuclei carry otolith signals. The rostral vestibular nuclei carry canal signals. So this is an otolith, central otolith disorder with a skew. Ask for vertical double vision in all your dizzy patients. Check for a skew in all your dizzy patients. It takes 15 seconds. And see if the eyes jump or don't jump. This is the skew pathway, if you will. We saw this a little earlier from one of Michael's slides. We've got our utricle going to the vestibular nuclei, crossing over, going up the MLF, medial longitudinal fasciculus, to impinge on 3, 4, and interstitial nucleus of Cajal. The rules are simple. In Wallenberg's, and with an acute, big labyrinthine lesion, the eye is lower on the side of the lesion, and the tilt is toward that side. With lesions in the midbrain and in the medial longitudinal fasciculus causing internuclear ophthalmoplegia, the eye is higher on the side of the lesion, with contralateral head tilt. So, vestibular nerve, vestibular nuclei, low. MLF, midbrain, high. And that's just the utricular ocular pathway, exactly comparable to a canal ocular pathway imbalance, only it's spontaneous nystagmus with a canal problem, and it's a disorder of eye alignment and counter-roll with an otolith problem. All right. How to think about nystagmus without getting a nightmare. And we've already seen someone sleeping in Dr. Stroop's clinic with a slow phase and a quick phase. And he was probably having a nightmare thinking about what was going to happen next. But and we learned that comes from a Greek word meaning drowsiness, nodding, or dozing off. Hitzig, a famous European neurologist, physiologist, first used the word nystagmus, actually in an ENT, a neurootological situation. He described the effects of galvanic stimulation on the mastoids behind the ears, and he produced what he called nystagmus, with slow and quick phases. And the eye movements were likened to a fisherman's float, a boat in the water, rocking back and forth, and it would go slowly in one direction, and then it would quickly go in the other direction. So let's deal with nystagmus. And what I'm going to try and convey to you today is a few simple principles. You know, there are 100 types of nystagmus. The international community has been arguing for 2 years on how to classify 150 types of nystagmus. We're going to hone it down. We're going to bring it down to a few general principles. So, it's a rhythmic oscillation. It typically begins with a slow drift of the eye. This is an important point. There are eye oscillations which begin with a saccade away from the target. Right now we're talking about an oscillation in which the problem is the slow phase. It begins with a drift away from the target. If the oscillation is equal slow phases, we call it pendular. If the oscillation consists of a slow phase and a quick phase, like Hitzig and galvanic stimulation, we call it jerk nystagmus. And of course, vestibular nystagmus is a jerk nystagmus. So, 2 types of nystagmus, pendular and jerk. Now, here are a few guidelines to help you organize your thinking about nystagmus. We can think of it as a disorder of the brain's way to keep the eyes still, so we can see clearly. Vestibular, classical form of nystagmus mechanisms. There are gaze-holding mechanisms. We'll talk about those. In the brainstem and cerebellum, we talked about these structures earlier. Just to repeat, these are gaze-holding integrator networks. For horizontal, it's in the medulla, the medial vestibular nucleus, nucleus prepositus hypoglossi. And for vertical, it's in the midbrain, interstitial nucleus of Cajal. And remember that the cerebellar flocculus and the paraflocculus are important for gaze holding. Now, There are also mechanisms that keep the eye movements calibrated. If you become blind, even sometimes late in life, after a period of time, your eyes start to develop nystagmus because the brain can't keep things calibrated. Another mechanism, sensory deprivation, can cause nystagmus. And now we know that there are ion channel disorders. Molecular biology finally getting into the clinic where the membrane stability is decreased, increased, and that can lead to nystagmus. Now, a second way to think about nystagmus is the waveform. I've already alluded to that. I'll show you examples of that. What you see, what is the waveform? And finally, there are some forms of nystagmus that defy classification. And we just have to recognize them. So once you see them, then you recognize them. All right, here's waveform analysis. We're all familiar with this if you do ENGs, for example. We have the slow phase with a quick phase, a form of jerk nystagmus. And here, the slow phase is a constant speed. It's linear, constant velocity. Now, a second type is when the slow phase decays. You look to the side, and the eye comes back, and it slowly, it decreases its speed. It's also a jerk nystagmus. It's often a gaze-evoked nystagmus. Occasionally, you see the slow phase go faster and faster and faster. The eye takes off, and then there's a saccade. That's typically congenital nystagmus. Typically congenital nystagmus. And finally, pendular. And that can be congenital or acquired. Now, let's talk about vestibular nystagmus. Ewald and Florenz did fabulous work in the 19th century, both using pigeons, on figuring out what each canal does if you stimulate it. And they worked in pigeons, as I said. Here's a little diagram which shows you, it's as if you're looking down on someone's head, and you can see the lateral canals are here. These are the vertical canals. The arrows tell you the direction of the slow phase if you could artificially stimulate those canals. Okay? So, Ewald's first law came out from here. We heard about his second law. The eyes rotate in a plane parallel to that of rotation of the head, detected by the canal in that plane, Ewald's first law. But there's some simple rules we can take away from this diagram. Pure vertical and pure torsional is almost always central. It's almost impossible from a peripheral lesion to get an absolutely pure vertical or an absolutely pure torsional. Few exceptions, but rare. And of course, if you just take out the whole labyrinth, and any of you who've done a labyrinthectomy know this, you see a mixed horizontal torsional nystagmus. You just add up the arrows and it all pops out. So if it has another pattern of nystagmus, you don't know. But if it's pure vertical, pure torsional, it's central. It may not be a disastrous disease, it could be too much medicine, but it's central. And if it's mixed horizontal torsional, it's almost always going to be peripheral. Now, this is a flow chart for classifying nystagmus. I haven't memorized this, but I carry it around in my wallet. So immediately I can figure out a patient who has nystagmus, but it's really simple. It just allows you to think rationally about this. It's an algorithm. So if it's a slow drift, I already said it's going to be jerk or pendular. If it's jerk, it can be unidirectional, and that's commonly vestibular. And then there are these rules for vestibular, which I just told you about: central, pure vertical or torsional, peripheral, horizontal, torsional. Now, if it changes direction on whether you're looking right or left, we call that gaze-evoked nystagmus. And that's often central. If it's acquired, we often see it with cerebellar disease, and it can be congenital as well. Now, if it's pendular, if it's acquired, we often see it in multiple sclerosis, or with ocular palatal tremor, or it can be congenital. And finally, we have these unusual forms, seesaw, Whipple's disease, etc. So what we're going to try and do is see examples of these and see how they fit into the algorithm. Okay, so what do you see?
Just look straight ahead. You're doing great. I look to the right. Look at my finger. Look at the camera. Look at the finger. So there's a little gaze evoke with a slight downbeat component. You're doing great. Just keep your eyes over there. Now look at the camera. And a strong rebound.
Okay. Gaze evoke nystagmus. A slight downbeat component, and what we call rebound nystagmus. Rebound nystagmus. Let's look at that one more time.
Just look straight ahead. You're doing great. I look to the right. Look at my finger. Look at the camera. Look at the finger. So there's a little gaze evoke with a slight downbeat component. You're doing great. Just keep your eyes over there. Now look at the camera. And a strong rebound nystagmus.
Slow phase in the direction in which she was looking.
Now we'll go over the other side. Look at the left. And look at the... Now look at the camera.
Okay. So, triad. Gaze evoke nystagmus, rebound nystagmus, and downbeat nystagmus. Where's the lesion? Who votes for the brainstem? Okay. Who votes for the cerebellum? Okay. Who votes for functional psychiatric? Very good. Yeah, 95% of the time, and so you're both right, but 95% of the time this is going to be a cerebellar sign. Very occasionally with a brainstem you might see this combination, but it's basically a cerebellar sign. Here's a couple examples of common examples where we see this. The Chiari malformation. You see the cerebellar tonsils are below the foramen magnum. And in the spinocerebellar degenerations, in particular what we call SCA6, and this is a dominantly inherited, late onset, very common of the spinocerebellar degenerations. The cerebellum is half normal size here. It's half normal size. The cerebellum should go to the occipital pole. Remember paraneoplastic syndromes in middle-aged folks, drug intoxications, and this is very treatable nowadays, probably in 50% of patients with the aminopyridines. So let me give you a few summary points about downbeat nystagmus. We saw that earlier. Downbeat nystagmus. You must exclude a paraneoplastic syndrome, and paraneoplastic syndromes are immune-mediated neurological disorders in which the cancer is not in the brain, it's somewhere else, but it's stimulating the immune system, and there's some kind of an inflammatory attack on the brain. In women, we see that with ovarian cancer commonly, lung cancer. There's a number of antibodies that should be tested, and these are sometimes treatable. Getting the cancer out or under control is usually the way to treat the nystagmus. Drugs can cause this. Carbamazepine, lithium, and amiodarone, that heart drug for arrhythmias, they cause downbeat nystagmus. Cerebellar degenerations, I mentioned that. Craniocervical junction anomalies. Wernicke's disease, we're going to talk about that more today. These patients can have downbeat nystagmus with the very curious phenomena that when they converge, the nystagmus changes direction. It goes from upbeat to downbeat or downbeat to upbeat. Treat those patients with B1 and magnesium if necessary. So 4-aminopyridines, this may work in upbeat nystagmus, possibly in episodic ataxia type 2. Michael Stroop put up some ongoing trials for this. And other drugs are not usually as good for downbeat. You do treat stiff person syndrome when they have anti-GAD with immune therapies, and that can be successful. You could ask your patients to smoke. Nicotine causes upbeat nystagmus. That would balance out the downbeat nystagmus, but the patient would get cancer. So you have to kind of put those in context. This is from Michael. It's a wonderful video. This was with 3,4-diaminopyridine. There's the downbeat nystagmus before treatment. And down here is after treatment. It's almost gone. And I've had a few patients where it's been just this dramatic. And they are happy patients. What's this?
This is Melanie Butler, who's had an acute onset of ocelot.
Is there a nystagmus there? Yes or no? Yes. Is it jerk or pendular? Who votes for jerk? Okay, who votes for pendular? Okay, it's jerk. We'll look a little more carefully. Is it beating down or up?
See a vertigo and some imbalance beginning just a few
So it's
days
an
ago.
upbeating jerk nystagmus. With upbeating nystagmus, the lids go a lot more often. I think it's called Pick's nut sign. There's often an associated lid nystagmus with upbeating nystagmus. There's some interesting reasons why that is, related to mechanics, but I'll let Dr. Stroop think about that. This is upbeating nystagmus. Okay, and when it's like this, we usually know where the lesion is. It's usually in the medulla, and it's usually in these nuclei called the perihypoglossal nuclei, right near the vestibular nuclei. I don't care if you remember the name, but remember the medulla. Here are the lesions there, and that would be localization of upbeat nystagmus. Now here's something very curious.
Right.
Look what happens when she converges.
Cross them hard.
It becomes downbeat.
My nose
Upbeat.
and the finger.
If you look hard, you'll have a
My
few.
nose.
It either stops or becomes a little downbeat.
With the
So
finger.
this effect of convergence on nystagmus is a bit mysterious, but there are some practical implications. The lesions for upbeat are commonly localized to the medulla. I told you the intercalatus nucleus. It's commonly seen in Wernicke syndrome. If you see a horizontal nystagmus that is suppressed by convergence, it's going to be congenital. If you see a spontaneous downbeat nystagmus that is enhanced with convergence or on lateral gaze, it's a central vestibular nystagmus. So downbeat nystagmus typically gets worse when you converge, and it gets worse when you look out to the side. Okay, so what do you see here? So is there a nystagmus? Yes. Is it pendular or jerk? It's jerk. There's a slow phase to the right, a quick phase to the left. And it's going to do something weird here. It's a little bit downbeat now. And now, which way is it beating? So it turned around. And every 2 minutes and 11.5 seconds it turns around. So who knows what this is called? Exactly. This is, it's called what you see. It's called periodic alternating nystagmus. It is a archetypical the classic central vestibular nystagmus. Who knows where the lesion is? Yeah, right in the nodulus. We know more about this nystagmus than almost any other type of nystagmus. It's unusual and it's quite dramatic, but we know its pathophysiology, we know its anatomical localization, and we know its treatment, baclofen. It makes up for the missing GABA that is absent when you have a nodulus lesion. Michael, has 4-AP been used to treat PAN? Does not work. Very interesting. So the idea is you actually have to bathe the vestibular nuclei with GABA to make this work. That's, sometimes you have to add memantine, another medicine, but it's very treatable. Okay, what's this? So is there a nystagmus? I think there is. Is it pendular or jerk? It's pendular. Does it have a specific trajectory? Well, we would call this elliptical nystagmus. It's a pendular nystagmus. Elliptical pendular nystagmus. So this is a very classical form of a pendular nystagmus. Let me show you one more case.
Okay, you're doing fine.
A little finer, but exactly the same thing. Watch what happens after each saccade or blink.
Nystagmus. Eye. Camera. Eye. Camera. Look at my eye. Blink. Blink.
Can you see it stop for just a moment? Who could not see that? Shall I show it one more time? I'll show it again. Let's finish this and we'll show it one more time because it's very distinctive and it's practical.
Close your eye. Open.
After the blink, when the eye's open, it's still for just a half a second. Let's see if we can run this whole thing once more.
Fine.
Watch what happens after every saccade. There's the nystagmus.
You see a little fine elliptical pendular nystagmus.
And it stops.
Eye. Camera.
Just
Eye.
for half a second.
Camera. Look at my eye. Blink. Blink. Blink.
So this
Close
is
your
pendular
eye.
nystagmus, very much like the previous patient. And it's curious, but saccades and blinks tend to stop it for just a moment, but that is practical because patients can learn to, when they're trying to do some fine visual discrimination, to either blink or just look away and look back, and then they can see clearly. It's like congenital nystagmus where they can take a snapshot of the world when their eye is still. We tend to see this in a couple conditions. I already told you what they were. Let's take a look at this.
Let's just take that. Eyes open. Just don't do anything. Just, there, we got it.
Oh, yeah.
See it going? Beautiful.
Could you see the palate moving up and down? So this is a palatal tremor. It used to be called palatal myoclonus. Now it's called a palatal tremor. And it's part of a syndrome with ocular palatal tremor where you see pendular nystagmus. The other thing, of course, that I told you was multiple sclerosis where you see this. Here's some of the lesions that create ocular palatal tremor. First of all, this is the inferior olive, and it's big and it's bright. It's hypertrophied and it has increased signal in this syndrome. And these are some of the lesions that cause it. Deep cerebellar nuclei, superior cerebellar peduncle. These are mostly cavernous angiomas, which caused this. And this was a pontine hemorrhage. This is iron, iron, iron. So these are some of the lesions. Anybody remember what the name of that triangle is? Yeah, very good. It's the Guillain-Molleret triangle. And cerebellum, and then up to the midbrain, down through the central tegmental tract into the olive, back to the, in the medulla, and then back to the cerebellum. Look in the mouth of every patient who's got pendular nystagmus. You'll see palatomyoclonus and you have a diagnosis. You'll know how to direct this patient's evaluation. All right, what's this? Oh, let me give you a clue, a clinical clue. If you're trying to decide whether the two eyes are doing the same thing or something different, look at the bridge of the nose and then let your parafoveal part of your retina take in both eyes. If you look at one eye, you're going to have trouble figuring out what the other eye's doing. All right. Let's seesaw nystagmus. Let's see if you can really see it. Can you see the eyes rocking? So look at the bridge of the nose. All right, here's something you're all going to see, and you're going to maybe get an ENG, and it's going to come back central. Please evaluate for cerebellar lesion or something like that. This was a young woman in her late teens, and she presented with headaches. And this is what her eyes did. So is it pendular or jerk? Or is it just plain hard to tell? Well, there are some jerks in there, but is it going in one direction or is it changing direction? So, you know, I like to describe this as sort of a Latin American rhythm, sort of a conga or samba or something like that. The eyes are kind of going back and forth, they're changing direction. If I can't tell what the nystagmus is doing, it's congenital. That's kind of a dumb rule, but it's not so bad. This is infantile or congenital nystagmus. This is what the eye is doing. It's beating in one direction, the eye takes off, and then it turns around and beats in the other direction. There's a foveation period after each quick phase when the eye is flat, and then it takes off. This is a velocity increasing slow phase that I mentioned to you. And then this is what we call a braking saccade. Braking saccade. So it stops the oscillation. This is congenital nystagmus. She had no symptoms related to that, but the headaches were kind of worrisome. Here's some key features of congenital nystagmus. So foveation periods, they allow for clear and stable vision. The duration, how long it's quiet, can often tell you how well they can see. And it allows for pretty normal visual development, even though they have this. As long as they stop for some small fraction of a second, the brain has enough time to get information in and keep itself calibrated. I think I'll move on and just finish with one or two more. Well, here's our flow chart again, just to remind you. Jerk nystagmus, pendular nystagmus, unidirectional vestibular, if it changes direction on right or left gaze, gaze evoke, that's acquired often, and central cerebellar. And remember, if it's pendular, we tend to see it in MS or in ocular palatal tremor, and then we saw a funny example of seesaw nystagmus. These patients almost always present with vertigo, and I would say 50% of the time they come to an otolaryngologist first. What does this lady have?
Down, straight at the camera. To my finger, or to the camera. Finger, camera. Finger, camera.
Anybody know what this is called? So this is opsoclonus. Opsoclonus. It's random saccades. It's not a nystagmus with a slow phase. The saccade takes the eye away from the target, and it comes back to back, just like this. It's called opsoclonus. And I bring this out to you because, again, the lesions or whatever causes this almost always has the patient first complain of vertigo, and they're often diagnosed as vestibular neuritis. Now here's another example of a very similar thing. Back-to-back saccadic oscillations.
Okay, we'll just do...
Anybody know what that is?
I don't know, I never tried.
Try.
She's doing this voluntarily. She is able to do it by using convergence, and this is what we call voluntary nystagmus. It's not a nystagmus. There's no slow phase. It's saccades. All right, this is your final exam. This is from a movie, a Paul Newman movie called Nobody's Fool. And so I was at this movie with my wife, and as usual, I was sleeping in the movie. And she saw this guy's eye movements, and she kind of, elbowed me and said, "This is what you do for a living, Dr. Z." So let's see what you can see.
Ron Nelson, one. I thought you said you were never going to work for Carl again. Shut up, Ron.
Oh,
I won't work on Thanksgiving.
I hope you can see it.
Fingers freezing. Fucking Thanksgiving.
The eyes were going back and forth there. I'll try and show it. Well, anyway, it's congenital nystagmus in an actor.
I thought you said you were never going to work for Carl again. Shut up, Ron. I won't work on Thanksgiving.
Oh, excuse me, those big pendular movements.
Fucking Thanksgiving.
All right. So I said the purpose of this talk was that I would hope you wouldn't have nightmares about nystagmus, so may I wish you pleasant dreams. Thank you.